Complications and caring for the patient experiencing complications during pregnancy is Chapter 6 in F.A. Davis. If you want to look in ATI, you can look in Chapter 7, Bleeding During Pregnancy, and Chapter 9, Medical Conditions, and then also a little bit of the end of Chapter 6, Assessment of Fetal Well-Being. So there's many complications that can happen during pregnancy. We're going to focus on a few. Bleeding complications that can happen in the first trimester, mostly. They can happen in any trimester. But most of the time when there's bleeding in the first trimester, we're thinking ectopic pregnancy or spontaneous abortion. Bleeding in the second and third trimester, you want to think more placenta previa or abruption. Because remember, the placenta isn't really even sort of taken over until about, weeks 10 or so. Metabolism issues that can happen are type 2 diabetes, pre-pregnancy, or gestational diabetes, which is an insulin resistance first found in pregnancy. So gestational diabetes is what we'll concentrate on. Although many women come to pregnancy with both type 1 and type 2 diabetes. Perfusion issues we'll talk about are hypertensive disorders of pregnancy. Preeclampsia is one of the biggest ones that we'll talk about, but also there's women that come to pregnancy already hypertensive, which are considered chronic. Then there's gestational hypertension. Preeclampsia is gestational hypertension with signs of organ damage. Eclampsia is hypertension, signs of organ damage, and then seizures. And then HELP is a particular syndrome. And we'll talk about it. It's hemolysis, elevated liver enzymes, and low platelets, which can also happen as either part of hypertensive disorders of pregnancy or preeclampsia, or it can happen on its own. Blood type incompatibilities between mom and baby are Rh and ABO. We've touched on them in the prenatal labs, but we'll get more into those as complications. So to go back to our first trimester bleeding complications, an ectopic pregnancy is any time a fertilized egg implants outside of the uterus. So we talked about fertilization happens usually in the fallopian tube, and then it travels down and implants into the uterus. An ectopic pregnancy is when it implants anywhere outside of the uterus. 99% of the time it actually implants still in that fallopian tube. So the patient presentation hallmark is going to be unilateral stabbing pain in the lower quadrant. So not, cramping, but a stabbing pain. That pain can be referred to the shoulder due to a ruptured ectopic pregnancy and irritation of the phrenic nerve by blood in the peritoneal cavity. So if anyone comes in and they have pain in their shoulder already, that's definitely going to be an emergent situation, and you're thinking that ectopic pregnancy has already ruptured. So unilateral pain, vaginal bleeding, a missed period, any abdominal tenderness, that should always be evaluated to rule out ectopic pregnancy. Risk factors include history of STI or sexually transmitted infections, pelvic inflammatory disease, any prior ectopic, prior tubal, any kind of issue with implantation or with implanting in the uterus can put a person at a higher risk for an implantation somewhere outside of that uterus, any kind of scar tissue. Treatment depends on whether it's ruptured or not. So if it's an unruptured mass that they're just lucky enough to find on ultrasound or, because of some issue with pain, methotrexate stops all rapid cell production, so it will inhibit the growth of the embryo. If a tube is ruptured, traditionally they would remove that fallopian tube via laparotomy. Currently, they'll do a incision to remove the pregnancy partially, and they'll remove that via laparoscopically. So hopefully they can save the tube, even if they didn't have to, or even if they couldn't save the tube. Education for you as a nurse is letting people know that you can still become pregnant if you only have one working fallopian tube. So this is going to be an emergency lab workup. So you're going to be starting an IV, you're going to be getting lab work, you're going to do a beta HCG, a blood type and screen, a CBC. So you want to be thinking, if you're seeing this type of patient, how am I going to react? What are they going to need? What do I do for them? So you want to be thinking about that when you're asked about it. So this is just showing you, this is the uterus where we want implantation to happen, and these are all just spots that there have been ectopic pregnancies. You can even have an ectopic pregnancy in the abdominal cavity. So there's various sites of an ectopic pregnancy, and again, depending on whether it's ruptured or not, you would either treat with medicine or treat with surgery. So other complications are spontaneous abortion. The definition of that is, spontaneous abortion is synonymous with miscarriage. It means the same word. What you're going to see in healthcare is spontaneous abortion, and that's pregnancy loss before the age of viability or pregnancy loss before 20 weeks. It's early if it's less than 12 weeks. Late is anything between 12 and 20 or 12 and 19 weeks, 6 days. Usually patients will bleed, they'll have cramping. If they get a lab test for HCG, it'd be a lower value than expected. So if you're 6 weeks pregnant, they have a value that they're expecting. Most of the time you'll get an HCG and then you'll come back in 48 to 72 hours to see if it's holding steady or to see if it's going down. Because again, in that first trimester, the HCG, those numbers of that because of the cell division, because of the multiplication, they're only supposed to be rising in that first trimester. So if they're lower than expected, or they're actually falling, that's something you want to look at as a provider and as a nurse. So risk factors, first trimester, usually they're chromosomal abnormalities. Infections can cause spontaneous abortion, any kind of immunologic or endocrine factors. They may not have any obvious cause. Second trimester, there could be chronic infection, recreational drug use, uterine, cervical defects, trauma, any kind of shock. The treatment depends on what's happening. So there can be expectant management. Sometimes dilation and curettage or DNC will happen. There are things such as a missed abortion. So sometimes women won't have bleeding or cramping. You just go in for an ultrasound and you see that there's no cardiac activity. And again, the treatment depends on the woman and her provider. They could take a watch and wait approach. Sometimes they want to just schedule a DNC. It depends on the provider and the woman again. If she is Rh negative, like we spoke about, Rh immune globulin, the RhoGAM, will be given to prevent antibodies. So it's a lesser dose for spontaneous abortion or miscarriage. But again, anytime that placental membrane can become compromised, you want to give an Rh negative woman RhoGAM so her body doesn't make permanent antibodies and doesn't permanently affect future pregnancies. So she will get a lower dose, but you are going to do a type-in screen to see if there's any issues and to see if there's that need for RhoGAM. It's very important with spontaneous abortion for Rh negative women that they're treated so they can go on to have healthy pregnancies later in life if they so choose. You want to assess her mental health, and you want to use therapeutic communication. You want to support, you want to, give her referrals to support groups, let her know it's not her fault. You just want to be careful with your communication and the way that you're speaking to your patient because it is a loss.